You don't need fancy measurements. You just need to understand several important factors. Number one, your lipid profile, was it obtained in a fasting state? Because then we can trust the numbers, because most of our calculations and investigations have always been pegged to the fasting state. Number two, what is your level of vascular risk? That really depends on clinical assessment. And this is something you can look up online, or you can ask your doctor, Doc, what is my level of vascular risk? Am I considered to be low risk, moderate, high, very high, or extreme, right? The calculation to figure that out is very well known. I already showed you. That's our atherosclerotic cardiovascular risk estimator. Again, it's available online, and we'll have a link for this in the show notes, because you can go and plug in your numbers and see exactly what that means. Now, if you're a woman, you may want to use Reynolds risk estimator. And again, I'll put in show notes for that as well. It's been described in women, but can certainly use it in men. There's just not enough data. And as I said, using the newer risk estimates is a little bit tricky right now. But that's what you need to know, right? You need to know, was it a fasting state lipid profile? What are my numbers? And how do those numbers fit? Or how does my risk category fit the numbers? Are these numbers good enough for my risk category, or should they be better? I'm certain that you don't want them to be worse. But number three, and this is only with the basic lipid profile, is probably the most important, because number three holds the keys. And the keys are, we want to know how much of that elevated lipid profile situation is due to insulin resistance. And turns out it is very simple to calculate. You don't need ApoB, you don't need LDL particles, you don't need any fancy measurements. All you need to do is to divide your triglycerides, assuming that you had a fasting lipid profile, by your HDL cholesterol, and you have your answer.